Hi and welcome. We will be starting a fresh topic in pathology today, that is inflammation. In our previous series of videos, we discussed cell injury, and today we will start another new topic, that is inflammation. Inflammation is again a vast topic. I will divide the topic into episodes. In this episode, we will be seeing what is inflammation, what are the cardinal signs of inflammation, the types of inflammation, that is acute and chronic, the events occurring in acute inflammation, that is vascular and cellular events. In our next episode, we will be discussing the mediators of inflammation and chronic inflammation. Okay, enough of introduction. Let's now jump into the topic. Inflammation is defined as the local response of any living mammalian tissue to injury from any agent. So, inflammation is local response of living mammalian tissue to any injury. When somebody attacks you, you will respond, right? The same way, any mammalian tissue also responds to any injury thrown on it. And this response is termed as inflammation. Roman writer Celsus, as early as in 1st century AD, described the famous 4 cardinal signs of inflammation. The original 4 cardinal signs of inflammation described are: number 1, calor, means heat. The inflamed area is warm. Number 2, rubor or redness. The area is red. Number 3 is tumor or swelling. The area is swollen. And number 4, dolor or pain. To these original 4 signs of cardinal inflammation, Virchow later added the 5th one, that is functio laesa or loss of function. The inflamed area loses its original function. So, the 5 cardinal signs of inflammation are: number 1, calor or heat; number 2, rubor or redness; number 3, tumor or swelling; number 4, dolor or pain; and number 5, loss of function. You must have had injuries in the past, and I am sure you must have felt or experienced these cardinal signs of inflammation yourself, right? For example, when you bump your head into something accidentally, what happens? You will feel pain, dolor. The area becomes swollen and red. That is tumor and rubor. And when you touch that area, you can feel warmth. That is calor, heat. That is the cardinal signs of inflammation for you. Okay, coming to the types of inflammation, there are 2: acute and chronic. Acute inflammation is of short duration, usually less than 2 weeks. It is the early response of the body to the injury, usually resolves very quickly and followed by healing. The process of acute inflammation is a continuous one, but for the sake of discussion, we will divide it into two topics: the vascular events and cellular events. Vascular events refers to alterations occurring in the microvasculature, that is arterioles, capillaries and venules. The alterations occurring in microvasculature during acute inflammation. We will discuss the sequence of events. The first thing which happens, that is the immediate vascular response to a injury, is transient vasoconstriction. Transient is temporary. So transient or temporary vasoconstriction. This may last from about 3 to 5 seconds to about 5 minutes, depending upon the severity of the injury. What follows next is persistent progressive vasodilation. So the first response is vasoconstriction, which is temporary, and then this is followed by persistent and progressive vasodilation. This occurs within half an hour of the injury. Vasodilation obviously leads to increased blood volume in the microvascular bed of the area, and this increased blood volume is the one which is responsible for redness and warmth, which we saw in the cardinal signs of inflammation. Vasodilation also elevates the local hydrostatic pressure, resulting in transudation of fluid into the extracellular space, and this is responsible for the other cardinal sign, that is tumor or swelling. This is followed by the next event, that is slowing or stasis of microcirculation, and there is also altered vascular permeability. The vessel wall or vascular wall in normal condition allows only certain things to cross. This permeability is altered in acute inflammation, and that is called altered vascular permeability. This altered vascular permeability needs a little more elaboration. In the initial stages, the escape of fluid is due to vasodilation and consequent elevation in pressure that we saw already, and this fluid is transudate in nature, but subsequently there is increased vascular permeability and characteristic protein rich exudate appears. In order to understand this vascular permeability thing, we have to understand the concept of Starling's hypothesis. Starling's hypothesis explains the mechanism of fluid balance maintained between the intravascular and extravascular compartments. This fluid balance between the intravascular and extravascular compartment is maintained by two opposing sets of forces: intravascular hydrostatic pressure and colloid osmotic pressure, and extravascular hydrostatic pressure and colloid osmotic pressure. Two sets of forces: intravascular and extravascular hydrostatic and osmotic pressure. Now the question is, what is hydrostatic pressure, what is osmotic pressure, and how they maintain the fluid balance between intravascular and extravascular compartment. I will explain that from the basics. The hydrostatic pressure is nothing but capillary blood pressure. That is the pressure of the blood in the intravascular compartment. The counterpart of this in the extravascular compartment is the hydrostatic pressure exerted by the interstitial fluid, which is called tissue tension. This hydrostatic pressure always forces the fluid outwards. That is, wherever the hydrostatic pressure is high, the fluid moves out of that area. Obviously, normal physics. Fluid moves from high pressure to low pressure area. On the other hand, osmotic pressure is the pressure exerted by electrolytes and proteins present in the fluid. That is, the pressure exerted by the chemical constituents present in the fluids. And this pressure acts exactly opposite to hydrostatic pressure. That is, wherever osmotic pressure is high, fluid flows into that area. That is, fluid always flows from less osmotic pressure area to higher osmotic pressure area. In simple terms, hydrostatic pressure pushes the fluid out and osmotic pressure pulls the fluid in. There is both hydrostatic and osmotic pressure in both intravascular and extravascular compartments. There is hydrostatic pressure in both intravascular compartment and extravascular compartment. The hydrostatic pressure in extravascular compartment is called tissue tension. And there is osmotic pressure in both intravascular and extravascular compartment. Obviously, both blood and the interstitial fluid both contain electrolytes and proteins. So there is osmotic pressure in both intravascular and extravascular compartment. And we also saw this hydrostatic and osmotic pressure act opposite to each other. And this balance between opposing forces is the one which maintains the normal fluid exchange. How? We will see that in detail. The normal fluid movement is from arterial end to the interstitial space and from interstitial space to the venular end. The fluid moves from arterial end to the interstitial space, and from interstitial space it is drained by the veins. And we already saw there is both hydrostatic and osmotic pressure in the arterial and venular end and also in the interstitial space. And we also saw the hydrostatic pressure is the pressure which pushes the fluid outwards, and osmotic pressure is the pressure which pulls the fluid inwards. Now in normal condition, what happens is, in the arterial end, the hydrostatic pressure is high, that is about 32 millimeter of mercury. And the plasma oncotic pressure at the arterial end is 25 millimeter of mercury. The plasma oncotic pressure, that is the pressure exerted by electrolytes and proteins in plasma at the arterial end, is about 25 millimeter of mercury. And I already told you hydrostatic pressure is positive and the oncotic pressure is negative. So the net pressure at the arteriolar end is 32 minus 25, that is 7 millimeter positive, because here hydrostatic pressure is high. So 7 millimeter of mercury positive hydrostatic pressure. And we know hydrostatic pressure is positive outward driving, and so fluid moves from arteriolar end to the interstitial space. As we saw, there is hydrostatic pressure and oncotic pressure in interstitial fluid also, but in normal condition it is small and insignificant. And the net result is 7 millimeter of hydrostatic pressure at the arteriolar end, which pushes the fluid outwards from the arteriolar region to the interstitial space. Now coming to the venular end, in the veins, the hydrostatic pressure is less compared to the arteries. The hydrostatic pressure here at the venular end is only 12 millimeter of mercury compared to 32 millimeter of mercury in arterial end. On the other hand, the oncotic pressure is same as in arterial end, because the composition or constituents of blood is same, the same amount of electrolytes and proteins. So the oncotic pressure is same, that is 25 millimeter of mercury. So the net pressure at the venular end, here the oncotic pressure is high. So minus 25 plus 12. That is a net pressure of minus 13. That is 13 millimeter of mercury of oncotic pressure. As we saw, oncotic pressure is negative. It pulls the fluid inwards. So at the venular end, there is a total of 13 millimeter of mercury pressure pulling the fluid inwards. So the fluid moves from the interstitial space into the veins. There is some amount of fluid left in the interstitial space, and this is drained by lymphatics. This is what happens in normal condition, or otherwise normal fluid dynamics. Now coming to our topic, that is inflammation and altered vascular permeability in inflammation. Here what happens, the microvasculature becomes more leaky and the proteins escape from the intravascular compartment into the interstitial compartment. That is, due to altered vascular permeability, protein-rich exudate moves from intravascular compartment to the interstitial space. This increases the osmotic pressure of the interstitial fluid, because as we know, the osmotic pressure is maintained by the proteins and electrolytes. Because there is an increased amount of proteins in the interstitial fluid now, the colloid osmotic pressure of interstitial fluid is raised. The interstitial osmotic pressure, which we saw as small and insignificant in normal condition, now becomes significant. And we know osmotic pressure always pulls the fluid inwards, and so the fluid moves from intravascular compartment to the interstitial space, or in other words, more fluid is retained in the interstitial space, leading to edema or tumor or swelling. Thorough understanding of the Starling's hypothesis and the dynamics of fluid movement between intravascular and extravascular compartment is essential not only in this topic but also in another topic, that is hemodynamic disorders, and that is the reason we discuss that in a little bit more detail. And now let's come back to what is more relevant to the topic in question today. We saw there is altered vascular permeability and consequent movement of protein-rich exudate into the interstitial compartment. Now, what is more relevant here is what causes this altered vascular permeability. Altered vascular permeability is caused by various factors singly or in combination. Those include contraction of endothelial cells, which is brought about by the action of some mediators of or chemical mediators of inflammation. This is usually reversible and is of short duration. Another factor is contraction due to mild endothelial damage. There is structural reorganization of the cytoskeleton of the endothelial cells, which leads to contraction of these endothelial cells. This again is brought about by chemical mediators. Another factor is direct outright injury to the endothelial cells, leading to cell necrosis of the endothelial cells. Due to necrosis of the endothelial cells, there appears gaps. Another factor is leukocyte mediated endothelial injury. Here, the endothelial injury is caused by activated leukocytes, which release proteolytic enzymes. And increased vascular permeability can also be due to the leakiness of the neovascularization. That is leakiness of the newly formed blood vessels during the repair process which follows the inflammation. Anyways, the point is there is altered vascular permeability, which leads to exudation of fluid. Now moving on to the cellular events. It includes two processes, the exudation of leukocytes and phagocytosis of the injurious agent by the leukocytes. This is a sequential step-by-step process, and the first event occurring is margination of the leukocytes. But in order to understand the margination, first we must know what is axial flow of blood and the effect of stasis on the axial flow. Axial flow refers to normal flow of blood in normal conditions. The normal axial flow consists of central stream of cells, which comprises the leukocytes and RBCs, and peripheral cell-free layer of plasma close to the vessel wall. In inflammation, as we saw, slowing and stasis of blood occurs. And this stasis changes the normal pattern of axial flow and brings the leukocytes, that is cells, towards the periphery. And this process is called margination. You can compare this with margination or movement of heavier objects flowing in a river towards the banks when the river has slowed down. When the river is rapidly flowing, any heavier object thrown into the river moves along the central stream. Yes, but when the same river slows down, we will see that heavier objects move towards the peripheries or banks and stay there or get accumulated there. Yes, the same thing happens in the blood also. When there is slowing or stasis of blood, the leukocytes, which usually flow in the midstream, now marginate towards the periphery. The marginated leukocytes now roll on the endothelium and get arranged like stones on the pavement. That is rolling and pavementing. They also adhere to the endothelial cells with the help of cell adhesion molecules like selectins, integrins, etc. What happens next is emigration or transmigration of the leukocytes through the intercellular gaps to the extravascular compartment. The leukocytes, which have adhered to the endothelial cells, now move along the endothelial surface till a suitable site between the endothelial cells, that is the gap between the endothelial cells, is found, and through this gap they throw cytoplasmic pseudopods and emigrate outside. And this emigration is a chemotactic factor mediated process. chemotactic factors or certain chemicals which attract leukocytes to the site of injury. Otherwise, the chemoattractants. They include substances like leukotrienes, components of complement system, etc. And these chemotactic factors are the ones which attract the leukocytes to undergo this process of transmigration. Once the leukocytes are outside, what happens next is phagocytosis, or the identification and killing of the offending agent by the leukocyte. This again is a sequential process which includes 3 stages: stage of recognition and attachment, stage of engulfment, and stage of killing and degradation. So the first step in phagocytosis is stage of recognition and attachment. This is initiated by the expression of cell surface receptors on the macrophages or the leukocytes, which recognize the microorganisms. The expression of cell surface receptors on the leukocytes which recognize the microorganisms. This recognition is further enhanced when the microorganism is coated with specific proteins called opsonins, which come from the serum. This process is called opsonization. So when the microorganism is coated with specific proteins from serum called opsonins, there is enhanced recognition by leukocytes. Examples of opsonins include IgG opsonin, C3b opsonin, etc. Once the offending agent is recognized, the next stage is engulfment. Engulfment is brought about by putting forth of cytoplasmic pseudopods. These pseudopods engulf the offending agent, and then the plasma membrane enclosing the particle breaks free from the cell surface, leading to the formation of a membrane-lined phagocytic vacuole with the offending agent inside, called phagosome. This phagosome then fuses with one or more lysosomes in the cell to form a bigger vacuole called phagolysosome. And this starts the next stage, that is killing and degradation. The offending agent is killed by antibacterial substances and degraded by hydrolytic enzymes. The killing process may be either oxygen dependent or oxygen independent. In oxygen dependent mechanism, there is generation of oxygen free radicals which kill the microorganism. Here, enzyme NADPH oxidase present in the cell membrane of phagosome reduces oxygen to superoxide. This superoxide is subsequently converted into hydrogen peroxide, and from here it can take two pathways called MPO dependent killing and MPO independent killing. In MPO dependent process, the enzyme myeloperoxidase acts on hydrogen peroxide in the presence of halides like chloride or iodide to form hypohalous acid, which is more potent antibacterial agent. MPO independent killing happens in mature macrophages which lack enzyme MPO. Here, hydroxyl ions and superoxide singlet oxygen is formed from hydrogen peroxide in the presence of superoxide or ion. On the other hand, oxygen independent mechanism does not require oxygen. Here, the microorganism is killed by liberated lysosomal granules like lysosomal hydrolases. Anyways, whether the process is oxygen dependent or oxygen independent, MPO dependent or MPO independent, the end result is killing and degradation of the offending microorganism. With this, we will end this episode. In the next episode, we will be discussing mediators of inflammation and chronic inflammation. So keep the channel, subscribe for more videos. As usual, PDF notes are available for download in the description. And if you need further guidance, you can mail me. Until we meet in another video, thanks for watching. Bye.